Can you tell me about a time where you recognised adverse changes in your patient's condition and how you responded? I had a patient present to the emergency department at the hospital where I was working. He came in because he was feeling generally unwell. So we made him comfortable in the emergency department. We then did a baseline set of observations, including BP, rests, oxygen saturations, temperature and pain levels. Most of these were within normal ranges on presentation. About 20 minutes later, he said that his condition was worsening and he felt that he was struggling to breathe. So I repeated another set of observations which showed that his oxygen saturations had dropped. His rest rate had actually increased. So I took this information then to my RN, who then came and checked over the patient, and we then made the decision that a doctor was to be called. The doctor presented, and then this patient was then actually later retrieved by a retrieval team and sent to Adelaide due to us being a rural and remote community hospital. And he completed his treatment in Adelaide. What is work health and safety? And can you give me an example of your application of work health and safety in clinical practice? The practice, work health and safety, is the practice in the workplace, utilising and implementing things to reduce the risk of hazards to all those within the workplace. This can be shown when using a lifter to lift a patient that is immobile or injured. The lifter requires 2 people to use the lifter and lift the patient, as it is a manual handling task. So to reduce the risk of injury to not only the staff members but also to the patient, it is to use a lifter at all times, and it's to be used in a manner that is taught as part of policies and procedures within the hospital. You have a Muslim woman going to theatre for a D&C post mid-trimester delivery for retained products of conception. As you prepare her for theatre, she refuses to take off her hijab. How would you manage this? Obviously, there's cultural considerations that need to be taken into consideration with this patient. She is Muslim and they do have their own beliefs. So I would be empathetic to her, as she may be anxious due to having to have a medical procedure in theatre. She may feel vulnerable. If she is of non-English speaking, I would obviously introduce her to an interpreter so that I could ensure that she was understanding everything that I was trying to tell her. I would just inform her on the importance of the theatre remaining a sterile situation, and that the hijab does impose some risk to infection control. Also, wearing the hijab may in some manner impede on the anaesthetist being able to fully monitor the patient's breathing. It may also restrict in some ways airways, and obviously helping the patient if it is needed. So just basically being empathetic to her and explaining the reasonings why the hijab can't be worn in theatre. Also ensuring that she's maybe offered the alternative of wearing a surgical cap or something like that that covers the head. Consulting also with the surgical team, maybe they may be happy for her to wear the hijab into the theatre and then have it removed during the procedure. But it's basically just keeping those open lines of communication and respecting her wishes. You have a 12-year-old Aboriginal girl from a remote community on the ward with query appendicitis. The RMO advises that he thinks her appendix has ruptured and that she will need to go to theatre ASAP. Her mother has gone uptown to do her Centrelink, banking and shopping. How do you manage this situation? Obviously consult with the RMO and let them know that the mother actually isn't present at the time. Trying to contact the mum also. Also emergency contacts, trying to contact those, utilising the Aboriginal liaison to see if they can help with the matter, or maybe even they could contact the mother or find the mother. Basically, the child and their health is of utmost importance, and the doctor can make the decision to continue if the child's health is at risk. So also helping the child. If her mother's not there, then she may be scared, she may not understand what's going on. So talking with that child and ensuring that she understands what's happening, beginning the pre-op procedures so that she's ready, and then still continuing to try and contact the mother. Hopefully, perfect situation, the mother would arrive. Otherwise, just dealing with the RMO, the Aboriginal liaison of the child, and hopefully the mother or any other community family members or elders. The boarder mother of a 6-month-old admitted to the ward with pneumonia returns to the ward after an evening off the ward. She appears to be intoxicated as she has an ataxic gait and smells of alcohol. She picks up her son and starts breastfeeding him. When you approach, she asks for some sandwiches as she has not had dinner. How do you manage this situation? First of all, I would obviously make the mother comfortable back to the ward, ensure that she's in a comfortable position with her and her son, where her or the child are not at any risk. I wouldn't presume that the mother is intoxicated, as other considerations need to be taken with conditions such as diabetes presenting with the same symptoms. So not automatically jumping to the conclusion that the mother is drunk. Just having a general conversation, inquiring about her medical situation, and if it is developed that she is under the influence of alcohol, being empathetic to the situation, but discussing with her and seeing if she understands the risk of alcohol actually passing through breast milk to the child. Obviously reducing the risk to the child as well is paramount. It needs to be done in a calm and respectful manner, because the last thing you want is the mother to become irate. She may then decide to leave or become quite aggressive or remove the child from the hospital, which then puts the child at further risk of the condition not being treated properly. She may feel comfortable developing the relationship so that she does feel comfortable to talk to you. Maybe the introduction of a social worker may be needed. Referrals for that. It might have been a one-off. She might never do it again. She may have had a bad day. It could be something ongoing. There could be other issues in place that we don't know about. So being empathetic and respectful of the mother, trying to protect the child, also utilising other agencies that may be able to help. But obviously also getting the mother something to eat and drink, because if she's diabetic or if she's been drinking, she's hungry at the end of the day, and you want to care for her too, because it's at the best interests of the child.